most people, a lot of people have logged in. I think we'll get started. For those who don't know, I'm Chris Van Buren, partner at KMRD, and I head up the employee benefits practice here. Today, we're going to cover some laws and rules that were passed in the last couple of years, and the resulting regulations are going into effect this year and really over the next year or two as well. So we're often talking to clients about the best and newest benefit offerings, how to build better health plans, how to control costs. And government regulations are typically more administrative and really not all that exciting sometimes. But most of what we're going to talk about today, these laws and executive orders, are what we believe an actual attempt to transform what the public gets to see in terms of costs and quality, what measures of responsibility employers will have in terms of how the money is spent on their plans, and eventually perhaps transform the cost of health plans. So most of you probably haven't heard nearly as much on these regulations as you heard about the Affordable Care Act or Obamacare. But these could have a much larger impact on the cost of healthcare, depending on implementation and enforcement. Some say these are the largest changes in employer health plans since 1943, when wage freezes were put in place during World War II, except for an exemption on health benefits, which essentially gave birth to the employer health plan system we have today. So as you can see from the agenda, we'll get into these laws, and to help us sift through these regulations, Doug Aldine is joining us from Austin, Texas. I could say that Doug's a great ERISA attorney who has worked extensively with health plans, representing employers, PPO networks, TPAs, and other entities involved with health plans. But as we've gotten to know him over the past few years, he's really a champion of trying to make the healthcare system better. We met through an organization called the Health Rosetta. That organization's meant a lot to us. I think it's meant a lot to Doug. And he's worked with us on some of the plans and with plan members that we have to fight the good battle and pay reasonable prices for health services. So Doug, with that, and welcome, thank you. Any comments on sort of what you're doing out there, or any thoughts at a high level before we get started?
Absolutely, and first, thank you for inviting me. This is awesome. Honestly, I think, when you talk about moving the needle and the ship moving in a direction where I think it's moving in a positive direction, I absolutely unequivocally think that. But it's like everything else. I mean, healthcare moves at a glacial pace, but I do think that the needle's moved and we're moving in a positive direction. And with all of the regulations and transparency and be able to connect all the dots and who's doing what to whom and how much and all these different things, it's really an eye-opening exercise. So
yeah. And so this kind of sort of a joke, but with the transparency we were talking about, it really is middle people. Middle people include brokers, advisors, consultants, as well as the carriers. And like the Capital One advertisement mentions, what's in their wallet. And hopefully a lot of what we're going to talk about ends up exposing what's going in and out of people's pockets and who's getting paid for what and what costs actually are, right?
Yep. So
before getting to some of those, some of the new rules, just want to do a little bit of background. So on fiduciary responsibility of employers. And so this is taken directly from the government's website, from the DOL's website. And so what you'll see highlighted in red, this has to do with retirement benefit plans. ERISA, which governs a lot of aspects of employee benefits, has two sides: the retirement benefits and health benefits. And here, this page is spelling out the fiduciary duty related to a retirement plan. And really, it makes it very clear that if you put your employees' money into with a vendor that has high fees and bad results, you can get sued. And really, soon after some laws around retirement plans, about 10 years ago or so, plenty of those lawsuits happened, and class action suits representing employees have been won. And one of the key issues in those lawsuits were broker fees that were in those plans. So when we switch, you may not have even noticed I switched, but highlighted in red is health plans and benefits. So DOL website, now it's talking about health plan fiduciary responsibility, and we see essentially the same language. The difference is health plans, they haven't had as much legal activity as retirement plans in the past decade or so, really in terms of lack of fiduciary oversight, but that certainly might change in coming years. And Doug, I think there's obviously going to be a little bit of a learning curve as employers understand their fiduciary responsibility with health plans. So just curious, what do you see happening out there or might happen, and what's key for them to understand before we get into the actual laws?
Sure, absolutely. I think the first thing I would do if I was an employer, I would look at your D&O policy. Do you have, fiduciary coverage? And if so, how much? I mean, just to see, where you are on the spectrum, because, you're going to want to have your flank, if you will, protected.
Yeah.
You understand, do you have it? And if you do or don't, how much coverage do you have?
Yeah.
Because think about, the exposure that's out there, it's significant.
And part of that is people are, like we said, I think most employers are very well acquainted since those extra regulations came out a little over a decade ago. People understand, hey, I'm a fiduciary of my retirement plan. And with some of what's come out recently, I think people are about to understand that they also have a fiduciary responsibility, and the government might take more interest on the health plan side of things. So let's get into some of the regulations. First, we're going to start with really what ends up having to do with compensation disclosure rules. So part of the CAA, or the Consolidated Appropriations Act, when that was passed, it really said that, hey, consultants and brokers need to disclose when it comes up on renewal time what they're earning from these plans. And there's no size limit to these plans. It's fully insured, self-insured. And really, when you get into who needs to disclose compensation, some people refer to this rule as the broker disclosure compensation. And so clearly brokers are a part of it, brokers and advisors. But it does get into anyone who consults. I'm not going to read through this whole list, but anyone who consults on a whole list of aspects on the health plan. And Doug and I were talking about this. I think clearly brokers have to. I think some things are going to have to be sorted out in terms of how deep does this go? Does it get to TPAs who get involved with various things? I mean, I would love it if lots of people had to disclose their compensation, but I think, for now, it's clear that brokers do and consultants on these types of things. Anything to add there, Doug?
Yeah, absolutely. So, with everything else and the dollars at issue here, there's a lot of sophisticated people. As an example, a lot of the large brokerage houses are moving their compensation from the employer paid portions of it to the employee paid. So, that gets you around, in theory, having to disclose, that component of the revenue.
Yeah. So to add some detail to that, what the law says is that compensation needs to be revealed when earning money on medical, dental, vision, and some of those other plans. It does not apply to group life, group disability, And then you can get in some of the voluntary products like accident, critical illness. And I think, you know, this is just sort of a hypothetical. This is a much bigger employer than some of the people on this call, but it shows that, you know, there can be a lot of sources of revenue. And what Doug's referring to that some people might want to watch out for is if they make their compensation look a little bit less on medical, dental, vision, and perhaps stuff that into higher commissions on some of the voluntary or employee paid. And so that's a possible loophole, but really what employers need to be expecting at renewal, and that was starting earlier this year, is they should be expecting a compensation disclosure. And so that can come in the form of actual dollars, a percentage of commission, a percentage of premium. It can be a PEPM amount, so it can be expressed in a few different ways, but that needs to be delivered. And so, you know, some people say, who's that on? Yes, the consultants and really any, you know, anybody earning over $1,000 on the plan needs to do it. But at the end of the day, it's the employer's responsibility to make sure that they've collected it.
You know, and so just kind of working with a number of folks, you know, in Congress through Health Rosetta, you know, one big issue is how is that supposed to be expressed? I mean, because we're advocating, you know, as transparent, you know, advisors, dollars. In other words, you're paying $28,000 because there's, you know, a lot of different brokerage houses that use very complicated formulas that require like a math scientist, you know, or a percentage. And it really, honestly, it's difficult. I'm not saying you're not disclosing it, but it's not really that easy to discern what that dollar value is.
Yeah. Yeah. And then you can get it, you know, on some of the plans, especially when they're self-funded, there can be a lot of different avenues that specialty vendors, whether it's helping with prescription drugs or chronic conditions like perhaps diabetes. This is one example that came out. We're blocking out who the actual consultant or broker was, but you know, this is a diabetic solution, and it's a matter of, okay, they brought that in. Doug, you've told me about things where there's dialysis solutions, right? Where people are perhaps earning some money and they're saying it's not the medical plan.
Right. And so, you know, this as an example. So this particular vendor, so think about this. I mean, they have a, you know, an F rating in terms of efficacy and quality, but you're making a tremendous amount of commissions. And so at what point, you know, does the advisor really need to disclose, wait a minute, I'm bringing this particular vendor to help you with your diabetics, but they're terrible. I just happen to make, you know, a tremendous commission.
Yeah. So, you know, as on this slide, as we talked about, whose responsibility is it to disclose deals and side deals? It's really the consultants are responsible for disclosing those deals, right, Doug? Yeah. But as a fiduciary of a plan, employers are going to need to make sure that they have received compensation disclosures from the vendors and consultants that they're using. Anything else on compensation disclosure, Doug, before we move on?
You know, I think that kind of covers it at a good high level. I'm interested in any questions, you know, as we kind of work our way through.
Okay. So someone asked, hey, I would have thought that the compensation would have been more of a look back. But it appears that the law is asking it for it to be a prediction, or, you know, what we're going to earn in the coming year. And so they're just asking, you know, to say, is that really the intent, that it's a look forward, not a look back?
Look forward.
Yeah.
Yeah, look forward.
Yep.
You got to be able to present it in a way where the plan sponsor can make a reasonable determination if they want to, work with you or somebody else. In other words, you got to make it so they can understand what they're going to be paid.
Yeah.
In a good faith way. Yeah.
Yep. And really, if you've made two options available, a Blue Cross or a Cigna, they should understand what you're making, what you would make on either of them. So that's a little bit having to do with the going forward as well, right? If you're presenting options, they should understand what someone is making on either option. Thanks for the question. So moving forward, transparency. So transparency in coverage. This is a big deal, so people can understand how big of a deal it is. If you'll see, if you look at this timeline, both the hospital lobby and the insurance lobby. AHIP up there represents insurance carriers, and so along the timeline from when the executive order went to regulations being passed, created, it's been challenged by high-powered lobbyists that didn't want it to go into effect, yet it's made it, and they've actually gone into effect. And just to emphasize a little bit of some of the entrenched players, the healthcare lobby, and in this graph, that means pharmaceutical companies, providers, hospitals, health insurance carriers, they're all in there. But I always find this graph a little bit interesting, that it's a mammoth lobby that really wields a lot of power. And they tried to stop this. Yeah,
I love that graph. The running joke is, we're $689 million away from fixing healthcare, which is the amount spent annually between big pharma, hospitals, and physicians lobbying members of Congress. So they're not going to Chili's for the 2 for $20. 2 for $20.
Exactly. So they've lost at every turn on these regulations, and really one of the key requirements is machine readable files, that it then allows third parties to allow what's going on. So this is the network rates that you have in your plans, whether you're fully insured or self-insured. Each health plan will be responsible to make these publicly available. And just to be clear, these are not at the individual claim level. This isn't data specific to any of your plan members, but instead it's the negotiated rate for in-network providers, historical costs for out-of-network payments, and prices for prescription drugs. And so this is going to take effect for plans that have plan years on July 1st or later of this year. And the picture I have here is United Healthcare actually sent out how they plan on helping their fully insured and self-insured. This was a website. I just took a screenshot of it, and they're going to be listing for each plan what those are. And really, so while this sounds like a big deal for employers, the carriers and the TPAs should be shouldering the burden on this. Doug, I don't know if you were about to say something on that, or.
I mean, if I think about this, we're 28 days away from this supposed to be in place. But, given the complexity and the cost involved, because I work with a lot of independent TPAs, it's a 7-figure investment to have this ready and available. So, there's leeway for sure, just kind of like there is with the hospital transparency stuff. But at some point, in the not too distant future, this is going to have to be available.
Yeah. Yeah. And so as this data, just a little commentary on this, which this isn't maybe to the average person, this isn't all that exciting. But as this data gets gobbled up by third parties, and I think this is just going to accelerate the cottage industry of vendors who have tried to use data to help health plans steer care to the best value out there. We should see employers who want to be proactive. They should be able to have much better knowledge about the true costs of the services they're paying for. And let's face it, whether it's fully insured or self-insured, that's what's going on. Employers' plans are paying for these services. That's the underlying cost. And they should be able to, in the future, as this gets going, and Doug, as you said, this isn't going to be perfect at first, but they should be able to craft better health plans that are much more efficient.
Look at Walmart does. Walmart has 18 different facilities across the country where they'll send people for, their spinal surgeries, hip replacements. That's where the market is going. I mean, because there's great physicians and facilities out there, and then there's also, by the same token, not so great and too expensive places. So,
yeah. And so you had mentioned this will be similar to what hospitals have needed to do. And so this is actually hospitals, and Doug, I forget if this went into effect in 2021 for hospitals.
It did. So year and a year and a half ago. Yeah.
Yep. So in a similar vein, hospitals have needed to make publicly available their negotiated rates. So for various procedures and their carrier and what they've negotiated with carriers. That does not affect employers, but all of this together should be better for the marketplace. And this is just an interesting example. So this is a local hospital, St. Mary's up in Langhorne. By the way, the Excel spreadsheet that you can download from their website goes thousands of rows down and dozens of rows to the right. There's lots of different health plans. For some you've never heard of, some are specific negotiations, but I just took a little capture of a few carriers that you may have heard of and really, 10 to 20 procedures. And just some of the interesting things, not just when hospitals report theirs, but when health plans will be reporting their costs, you just get to see some of the variations. I mean, on this first yellow line coming down, Independence Blue Cross probably is not really thrilled with what Cigna's negotiated contract rate is for this, right? And then Novitas Solutions is most people probably haven't heard of them. They're a Medicare contractor for the government. So that even shows that's what the government's getting. And then some of the variations of what the carriers are getting. And then you'll also see there's just non-compliance with a whole bunch of carriers. What I didn't show you is dozens of carriers where NA is there, right? And Doug, you've seen this in other examples, right?
So, as an example, IU Health, which is in the backyard of Anthem. Every single carrier is listed but Anthem. Why is that? Because they're the most expensive one. They're paying the most money to Anthem right in their backyard. So, you provide Aetna, Cigna, whoever else. But the gamesmanship, the lack of enforcement, and even if there is enforcement, it's what, $300 a day, so $109,200 a year. That's an ER visit. So I mean, it just doesn't really matter.
Yeah. So, but I think this shows you, when you've heard over the years that they haven't wanted to reveal this stuff, this one, shows you St. Mary's doesn't want Independence knowing what Cigna got. The same way Independence doesn't want a certain hospital to know what they've negotiated with. They've wanted all of these things under wraps, for sure, right?
Think about it. It's the same beer at the same bar at the same time. They charge Chris $12,000. They charge me $5 solely based on his great insurance. I mean,
Yeah. So what also comes along with the transparency in coverage is consumer price transparency tool. So beginning next year, this is not this year, but beginning next year, health plans, so that means the carriers, it means TPAs for self-funded plans, are going to have a portal that is going to help people understand their costs. And I know carriers' portals have been moving this way, but this should be much better information. So instead of real ballpark type of stuff saying like, oh, the average cost of this X-ray or this MRI is this, they should be giving employees, they should be giving them the actual negotiated rate for that. So in your plan, the coverage you have, it should be saying what the cost is going to be. And they're also going to have to put in the information of if you have this deductible or this copay or this out-of-pocket maximum, someone should be able to go in and look up this procedure. Now, they may have to get some details from their doctor's office or the surgeon that they're going to go to. They may need to understand the actual coding or the real named description of their procedure, but they should be able to go into these portals and understand where I am in the year with my plan, with my deductible, with my copays, and where I'm going to go. I should expect that this is going to cost me X amount of dollars. And so in the first year, the government's saying that there's about 500 procedures that it's going to need to be done. And then in 2024 and beyond, it's going to have to be pretty much all of the services. So this is a heavy lift for carriers and TPAs, but it should be very helpful. Doug, before we move on, any other high-level thoughts on transparency and coverage before getting to the No Surprises Act, or no?
I'm going to talk about a little bit here are the gag clauses here at the very end here.
Yep.
You know, everybody should, for all contracts moving forward at the beginning of this year, so January 1 of 2022, all that de-identified claim information should be at your disposal and at your fingertips. So contracts that are being entered into, you're entitled to that information. So the days of the book is, you know, telling you to take a hike shouldn't exist. Digressing,
Gotcha.
I can tell you what Cigna's position is. Cigna takes the position that they own the data, and the plan has a right to access it. I disagree with it. I don't know what their response is now that, you know, they're going to have to provide it. I guess we'll just have to wait and see. But it should be that.
Gotcha. So the No Surprises Act, sort of the irony of the name of this, just at a high level, the irony of surprise bills is that sort of the least interesting or impact. Surprise bills represent sort of the least surprising. I mean, some people joke that every bill in healthcare is a surprise bill until we get actual more transparency. But this law, what it's talking about, and this was part of the CAA as well, this has to do with if people go to an in-network facility. So you're going to a building, whether it's a hospital or a surgical center, that you know to be in-network. However, there are practices, there are physician practices walking around inside those four walls that might be out of network. One of the most often referred to are anesthesiologists. So you can go in and think that you're in network. Some out-of-network providers have seen you while you're there, and you end up getting, to your surprise, an out-of-network bill. And so what this act is saying is that's not allowed. And there's a procedure that carriers or your TPAs are going to have to go through so that the member cannot receive an out-of-network bill at and they list the type of places. in-network providers, you can't get it, emergency rooms. So there's a number of things in this law that you're not going to be able to get those surprise bills. And the government has outlined procedures for the provider and the carrier or TPA to go through a process that they come to an agreed upon amount, but that should all be, the employee should be blind to that process on how that provider is going to get the fair payment. So when you're talking about this, you know, so how will this work? Most of it should be behind the scenes for employees. Employees should know. I would think of it as, you know, if people are getting something where they think they're being overcharged, we should be talking to employees about, hey, talk to us, the broker, the carrier, the TPA. Just know that those scenarios should not be happening. The other thing that employees should know about is there might be waivers. So especially for non-emergency things. If someone knowingly goes to an out-of-network provider, there's templates out there already that these providers might be saying to the plan member, sign this waiver, and it's essentially signing away some of the protections from this act. So, Doug, any thoughts about the No Surprises Act and what people might be seeing?
Yeah, you know, my hospital lawyer friends tell me it's not really going to be that big of an issue because you think about this. I mean, I think hospitals have more to lose because, you know, you're going to have to be really confident that the qualified payment amount that you receive from the plan isn't sufficient. And, you know, because if you lose, you know, you're setting a market rate and everybody's going to know, you know, what that radiology service is going to cost in that particular market. And I think hospitals, honestly, just really aren't going to be that interested. I'm going to be curious to see how this evolves, but they have.
When you say interested, you mean there's sort of the arbitration process that they can go through, right? And if anybody's familiar with sports, they've even said it's sort of modeled after sort of baseball's arbitration process, where one side submits, the other side submits, and then if they've really gone down an appeals process. Again, this should be behind the scenes from the employees, but you're saying you're hearing from people that they're not going to be that interested in going down that arbitration process. Interesting. So this should be more behind the scenes information, but it just should be, employees should understand that they shouldn't face these scenarios, and they should think twice, or at least talk to somebody before signing any waivers. That's more for planned things. If they've actually planned to go to an out-of-network provider, they might be presented with a waiver. So gag clauses, Doug, you mentioned those a little bit earlier. So people may not be as familiar with these, but there have been in the past, there have been agreements between health plans and providers that have made it that information about cost and quality. And so that's one of the key things here is there have been agreements in the past where they've said this can't be revealed. Either the health plan hasn't wanted it revealed or the providers haven't wanted it revealed. And so this outlaws those agreements. Doug, you want to talk historically what some of the things that have gone on with gag clauses, what we haven't been able to see?
I mean, so, you know, if you pull any BUCA, you know, PPO agreement or network access agreement, you're going to be limited in terms of your right to audit. You're going to be limited in terms of the type of data they're going to provide to you, if any. All subject to, you know, all parameters and timeframes, and you can get 18 months, you can't get the historical data, all the different things that really just don't provide you a real glimpse of how those plan dollars are being utilized. And that can't be in there. So moving forward, to your point, I mean, all of that information should be available, at your whim, completely de-identified, and historical data. So from, time immemorial to, whenever you terminated from, Cigna, that should be,
Yeah.
At your fingertips.
Yeah, and this really speaks to what you had mentioned before, this ownership versus access. The carriers have historically thought, and they act as if this is my data. And okay, there's some rules about what maybe I'll share with you. And hopefully this is the beginning of a new era where really, obviously privacy still has to be held to, and we're not sitting there getting information about Chris's actual claims, but there's so much data that they consider proprietary, which really should be available to all of us as we, as advisors and employers, are trying to craft plans. It really should just be available to us so that we can make better decisions when building a plan, and then employees can make better decisions when using the plan.
And not only that, but you're fulfilling your fiduciary responsibility. In other words, how can you fulfill your responsibility to manage those plan assets prudently if I don't even know how my dollars are being utilized? You can't. So,
yeah. So looping back to the beginning of fiduciary responsibility, that, yeah, I mean, some of it's if especially fully insured plans, and I'll be curious how this goes over the years. That I'm not picking any of the big carriers. Doug referred to Buca, so that's Blues, United, Cigna, Aetna, and Humana sometimes is added in there. If they're not spending the dollars well right now on a fully insured plan, how much as a fiduciary can I be responsible, for that? But as time goes on, with more of this being exposed, there should be a greater expectation that we can spend these dollars better.
Yep.
So, I'm taking a look at Q&A. There's a comment that has to do with, back to the beginning, Doug, you had mentioned checking your fiduciary liability and your D&O. So just from our property and casualty experts, just mentioning that it can be packaged, just a note here, that it can be packaged with a D&O policy, but a standalone D&O will not likely trigger on a claim alleging an employer did not act in the best interest of an employee.
Yeah.
The recommended question for people is, do we have fiduciary liability coverage, and what is the limit? And so, that's just just a side note there for that.
That's a great distinction. Thank you, Robert.
Yeah. So I think we answered this already, but Doug, do you see this new set of rules? And so this came from an executive order. It came from the CAA. So it came from a few different areas, but really what I find interesting is it crossed over administrations, and it really doesn't seem to be one administration saying, no, I didn't like what started at the end of that administration. So I'm curious, do you see this as positive or negative for employers? I think I know the answer, but
I think it's absolutely positive because you had mentioned that all those data ninjas that are out there. You're building a whole new ecosphere of people connecting the dots. And I've got my friend Leo Wisniewski in Philadelphia with Healthcare Cost Labs. Just taking all of that information from these facilities, but then you're connecting all the dots, and you're seeing that it's insane. I mean, it's never been a functional system to begin with, but I think that there's an opportunity to streamline it and actually make it a functional system over time. I really do.
Yeah, that'd be good. And what I find interesting is usually when you hear more compliance, employers are burdened with things, and with this there will be some things that employers will have to keep their eye on. But really, a CFO and management at a company should like this new set of compliance. Like I said, there will be things that they'll have to keep their eye on. But unlike a lot of compliance that gets handed down, it shouldn't be real heavy burden cost for the employer. Some of the employer's vendors are going to have to get their acts together. And yes, the employer and advisors will have to keep an eye on that to make sure it gets done. But really, CFOs should be happy about these.
Not just, if healthcare, if wages and salaries are your number one spend, inside of an employer, healthcare is going to be number two. And so to be able to monetize and understand what you're paying for, how is that bad? It's great.
Yeah. Okay. Well, we've gone through most of the questions that people had. This was our prepared amount. We wanted to make it brief, but hopefully, give a good understanding of what is here and what's coming down the road. Doug, thank you so much. Like I said, on this, you've been helpful. And when we've worked on some of the intricacies of plans, it's been great. So hope some good music festivals and such are coming your way in Austin.
Steely Dan Sunday night. Beat that.
Nice.
Yeah. But thank you.
Very cool.
For having me.
Yeah. Well, thank you so much for joining us. Really appreciate it.
All right. You guys have a good day. Thank you.
All right. Thanks.
Yep. Bye.